We are live.
Good evening, everyone. I'm Dr. Tinku Bali, and on behalf of the Academics and Research Committee, I welcome you all to the 111th episode of our PG teaching program. So, today's topic, artificial intelligence in ophthalmology, what's new, is both exciting as well as very relevant to the present times. Because artificial intelligence is no longer just a buzzword. It's actually transforming the way we diagnose, treat, and actually look at the entire eye care system. From screening for diabetic retinopathy to predicting and prognosticating retinal diseases, glaucoma, also microscopes with inbuilt artificial technology. So AI is actually poised to transform the very face of ophthalmology in the future. Today, to take us through this changing scenario, we have one of the finest minds in the field, Dr. R. Kim. So it gives me great pleasure, sir. It's a great pleasure and privilege to have you with us today. Thank you so much for sparing time. So, to give you an introduction to Dr. Kim, he is a vitreoretina surgeon and the Chief Medical Officer and Director of Information Technology and Systems at the world renowned Arvind Eye Hospital, Madurai. Dr. Kim has been at the forefront of innovation, and his work in integrating technology with eye care has been truly pioneering. So, just to name a few, he's been at the forefront in integrating screening for diabetic retinopathy into a lot of systems at the Arvind Eye Care, along with Google, and he's also been a recipient of a lot of awards in this field. So we are truly looking forward to your insights, sir, and to the updates in AI. It's something very new for all of us, and looking forward to your talk. Joining us also today is an expert panel. So we have some very distinguished experts, Dr. Ajay Arora, who's the director of the Vision Plus Eye Center, Noida. Dr. Ronnie Jacob George, who's a consultant at the Glaucoma Services at Shankar Nethralaya, Chennai, and Dr. Anil Gangve, who's consultant vitreoretina services at the MGM Eye Hospital, Raipur. So we look forward to your expert comments and perspectives at the end of the talk. With that, I request Dr. Kim to please share your slides, sir, and invite you for your talk. For the audience, do keep your questions coming. So it is something very new, but very useful for the postgraduates. You also have a long question in the exams, on AI. So do keep your questions coming in. We have a chat box, and you're welcome to post your questions there, which we'll take up. So, Dr. Kim, over to you.
I, I hope you can see my slides.
Yes, sir.
Yes.
Thank you. Thank you, Dr. Tinku, for the introduction and the opportunity to share a little bit of what we've been doing with the AI. I'm not really the expert. I'm not a technical person at that. It's more on understanding, trying to fit what is new in technology into your practice, trying to be relevant with the time. So that's how this has come up. And so I'll share what little I know about using AI in ophthalmology. So we keep talking about, everywhere, any website you open, there's a chatbot to help you. And so we may soon have a Dr. Bot like this, AI specialist who could be, seeing patients in time. But this is just for the little bit of humor there. But just to start with, I'm sure every one of us who's using a smartphone are aware that we are using AI in every possible way. And it's not now, we have been using this without our knowledge for quite some time, be it photos, be it your contacts, be it you searching for something in Google or YouTube. It keeps prompting and gives you the right thing, and even the Google Maps. So there are so many things that AI is being used in our day-to-day life. And it's not just healthcare, but in every aspect of our life, today AI is creeping in. So what is AI? It is a different type of that is the machine learning, which was which gives the computers the ability to develop algorithms on their own without being explicitly programmed. They just learn like the humans, how we learn by reading books, by seeing things. The same way the computers can learn, see, listen, and speak. As many of you may have experienced, your phone would sometimes, I've had this quite a few times, that it starts answering without you asking them anything because it's listening to you, and some words that hit, it's able to recognize and give you some answer. So under artificial intelligence, which has been there since the 1960s, it didn't take up because of the computer power at that point of time. With the current capacity or improvement in the what is available to us, the hardware that is available today, this has become a reality. I wouldn't go into the technical details of what these are, but why it is important to us. Why apply machine learning to medicine? Today, we have lots of data to look through. And even for the human mind, there is a definite area by which you cannot go beyond. Whereas these machines can look at the data, can crunch this data within few seconds and bring out what you need. And each one of us have experienced that in many ways in the recent times. So algorithms can scale and enhance your expertise. So why AI in ophthalmology? We all know ophthalmology is data rich because we use a lot of fundus photo. We are basically doing a lot of image-based diagnosis, be it cornea, be it the posterior segment, retinal diseases. Many of them, most of them are image-based. And so it becomes apt next to radiology. I think uh, ophthalmology finds a major role in using AI, and it is ideal for AI analysis. And many of you may know that IDX, the algorithm for diabetic retinopathy developed by Michael Abramoff, was the first healthcare AI to be approved by FDA. Subsequently, many got, but that was the first one, and it was a big thing at that point of time in 2016-17. So what can AI do? First, it can automate repetitive tasks, things that I can do but are not good use of my time. There aren't enough of me in the world to do them. Like simple thing as looking at an image, you can train any of your technicians to show them the fundus image and say, this is a hemorrhage, this is this. And over time, he also learns. And whenever he takes a photo, your technician will say, sir, this patient has got diabetic retinopathy. This patient has CSR. He learns it because it's there, obvious. And similarly, the AI or the machine learns from the way we keep showing them these images. So we have been doing this diabetic retinopathy screening for the last 20, 25 years. In different diabetic clinics, we have put fundus cameras where the technician is taught to take pictures. They send it to our reading center where one of the retina specialists grades the images, generates a report and sends it back to the diabetic clinic where the patient originated from, giving a report saying his eyes are affected or not affected, and he needs probably an annual exam, or he should immediately see an ophthalmologist. And this usually takes about 1 to 2 hours, the whole process. And it is available during the daytime. So, but the problem of a doctor wasting this time is not good. And at that same time, when we were doing this in 2007, 8, we were looking at these, hearing about image processing coming up in different engineering institutions. They would come and look at our images. They would identify a red lesion or a yellow lesion, and that they would publish a paper and would go away. Later in 2012-13, when Google approached me and Dr. Rajiv from Shankar Nethralaya, we started working with them by annotating multiple diabetic retinopathy images. And that's how this whole story began. And we did about 130,000 images, labeling them. And over a period of time, there was not just us, there were a few other centers which shared these images by labeling the different grades of diabetic retinopathy for the AI to learn. at that point of time in 2013, it was 2014, it was too early, and people were just coming out with different AI algorithms at that point of time. I just wanted to share this interesting video. I'm sure people will recognize this video was done here by this person who's going to speak. His team came and did this whole video at Arvind. So I'll just share this video. I hope you can catch the audio. You're getting the audio, right?
You know how they say there are two certainties in life, right? Death and taxes. Can't we get rid of one of them?
Are you getting the audio?
Yes, we're getting
Yes,
the
sir.
audio.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yeah, I hope all of you recognize who this guy is.
Yes.
This is Robert Downey Jr.,
Yes.
the Iron Man.
Those? See, 100 years ago, life expectancy was only 45. Can you believe that? And then by the 1950s, it was up to 65, and today it's almost 80. Tomorrow, who knows, right? Healthcare has made huge progress. We've eradicated epidemics that used to kill millions, but life is fragile. People still get sick or pass away for reasons that maybe should be someday curable. What if we could improve diagnosis? Innovate to predict illness instead of just react to it. In this episode, we'll see how machine learning is combating one of the leading causes of blindness and enabling a son with a neurological disease to communicate with his family. AI is changing the way we think about mind and body, life and death, and what we value most, our human experience.
Is that diabetic retinopathy is one of the leading causes of blindness worldwide. This is particularly true in India.
Sir, excuse me, konja gavaninge.
Diabetic retinopathy is a condition which affects people with diabetes. In the early stages, it's symptomless, but that's when it's treatable. So you want to screen them early on before they actually lose vision.
So there's a hemorrhage. All these are exudates.
Dr. Kim called up a team at Google. Made up of doctors and engineers, they're exploring ways to use machine learning to solve some of the world's leading healthcare problems. The team uses the same kind of machine learning that allows us to organize our photos or tag friends on social media: image recognition. First, models are trained using tagged images of things like cats or dogs. After looking at thousands of examples, the algorithm learns to identify new images without any human help. For the retinopathy project, over 100,000 eye scans were graded by eye doctors who rated each eye scan on a scale from 1 to 5, from healthy to diseased. These images were then used to train a machine learning algorithm. Over time, the AI learned to predict which eyes showed signs of disease.
I think an imaginable future for AI in healthcare is that there is no healthcare anymore because nobody needs it. You could actually have an AI that is directly talking to your immune system and is actually preemptively creating the antibodies for the epidemics that are coming your way and will not be stopped. This will not happen tomorrow, but I think it's the long-term goal that we can point towards.
So based on that, this is the tool, just putting this within a few seconds, it gives the grade of that image and tells us what to do. So today we have replaced in our screening program with the AI tool. There's no dependency on any retina specialist, and the physician or the diabetologist is able to get a report within a few seconds and need not wait for any time. And the best part is it is available 24 hours, 365 days at any time he is seeing the patients. So we have been using it in our primary eye care centers as an assisted tool. And I was just looking at the data before using AI versus after using AI, we realized the number of cases identified went up by, we were looking at more patients in this point of time. We were also looking at the diabetic clinics versus the primary eye clinics. We realized the diabetic clinics have 3 times the prevalence rate of diabetic retinopathy because you're targeting diabetic patients. So this is why I keep telling that everybody should, encourage their diabetic colleagues to do diabetic screening so that they identify more patients early on. So it's not just diabetic retinopathy. As we said, any image-based diagnosis should be possible. And today we have been experimenting using an algorithm for retinopathy of prematurity in our telescreening programs. We're also looking at conditions like corneal ulcers. If you can identify fungal versus bacterial by just looking at the image, and looks like it is possible. Of course, it needs a lot of data. And so that, even in the remote rural areas, with just an image, you can start treatment, the appropriate treatment for those cases. Of course, in glaucoma and age-related macular degeneration are another two conditions which is really being explored world over by using AI algorithms. So what else can AI do other than automating repetitive tasks? It can find new signals, things that our eyes can't see, something like prediction. Can you detect DME from the diabetic macular edema from the fundus photos with the accuracy of OCT? Looks like it is a possibility. Dr. Raji Raman has been working on these two things, like prediction, treatment prediction for using anti-VEGF. If we know which anti-VEGF this patient is going to respond to, it will save a lot of money, time for the patient and for the doctors. So this looks like it is a possibility. I think they've explored on it and having good results, but of course it needs a lot of validation, and that is what is going through at Shankar Nethralaya. We've been working with Google to see, just by taking an external eye photo using a simple smartphone, you can identify many conditions like systemic factors, like for the liver, albumin, aspartate aminotransferase, for kidney, the EGFR, and so many other things. Looks like these are possibilities. So we are still working on different data to see whether this is in reality the same as doing a blood test versus just taking an external photo. But looks like it is possible. This is another important use case, I think, predicting the risk of developing diabetic retinopathy. A patient who's coming today, a diabetic patient today who doesn't have any retinopathy, what are the chances he will develop diabetic retinopathy in the next 5 years? There are some signs in this which AI is able to identify. And of course, this will help in a big way to understand who are the high-risk patients, and they could be followed up very closely with optimizing their sugar levels and stuff like that, so that their chances of developing diabetic retinopathy is well controlled. This is another area we're also exploring along with the University of Ann Arbor, Kellogg's. So on using for AI for surgical skills of trainers, like, how do they perform, the postgraduates, the residents, those are some things that are being experimented at this time. The other one is using federated data, transforming clinical data into fair data, which is findable, accessible, interoperable, and reusable data. This platform will facilitate secure global collaborative research. What it does is your data will never leave your premises, and you could be using the algorithm can come in, work on your data, and then go out, so that your data privacy is maintained, but at the same time, you can use the AI tools. So this is something that we are working with today with the University of Massachusetts. We are doing a project called CODA, and trying to do for few conditions, just as a experimental pilot project. So the convergence of modern multimodal imaging techniques and the large data sets that are available is able to characterize health and disease. So there is a role in identifying ocular biomarkers for various systemic diseases, which is being termed as oculomics. One of the potential avenues of this oculomics revolution is leveraging of the retina to gain insights beyond the eye, which many of you have heard about the Sundar Pichai talking about how fundus photos are being used to predict the cardiovascular risk factor for a patient? Can we identify Alzheimer's disease even before it starts? Parkinson's disease, kidney disease, looks like it is possible. But then again, it really needs a lot of longitudinal data, which people are collecting and working on to see if these factors, just by looking at the retina, when we said eye is the window to our body, it is really true. By using these fundus photos, we are able to identify the risk for various systemic diseases. And combining imaging and data, there's been this Cindy Kai from Hopkins has been working on this to understand, bringing a lot of data, millions of patients' data to understand is the risk of kidney failure associated with intravitreal anti-VEGF exposure in patients with retinal diseases. And her hypothesis was there is a lower risk of kidney failure in patients exposed to ranibizumab. But what they found out is it is not just ranibizumab, but all the other 3 drugs, it was only lower, it was not high as it was found. And this came out because of the large data that was made available to them, 6.1 million patients. So using data, you can do a lot of learning from not just image data, but also text data can help us to bring in a lot of information. And people are finding a lot of associations by looking at huge sums of data. So AI also promises to reduce clinical burdens significantly. I want to talk about a few use cases which we are trying to experiment on is creating case summaries, speech to text transcription, automated report generation, digital prescriptions, identifying disease progressions, and getting second opinion. It is seen in one of the studies that on average, a clinician spends about 3 hours generating clinical documentation and 1 hour searching for information every day over the internet, the EMR, which they are using. So we have been looking at, can we, especially the retinal surgeons have patients who have multiple visits, like we have 50, 100, 150 visits. Is it possible to look at that, scan through this data in a very short time? It is a real challenge. So is there a way we can have a summarization of this patient's data that gives us exactly what we really want to know? This is one such data summarization of a patient who had multiple visits. So it gives a patient summary. On the bottom, what you're seeing is multiple times the injections were given, and on each visit, what was the OCT, IOP, visual acuity, thickness, and things like that. There's also a chatbot on it in which I can ask for which injection the patient responded very well, or did the patient have any unusual events in the past, and things like that. So you immediately get an answer instead of scrolling through this. And these are possible because AI is able to go through, read all your previous visits and bring about the information that you need. This is another.
What is your complaint?
Sir, I had an eye injury last 2 days back, sir.
This test பண்ணி பார்த்துட்டு pass
சரிங்க sir.
So examination of the right eye, there's a foreign body in the temporal aspect of the right cornea, and there's no macular edema.
So the doctor, once he talks, he doesn't enter any data. The patient's information is captured in the right complaints column. Ocular history is put in the ocular history column. And when you're explaining about as you're examining, when you're explaining, it is putting all that in the right boxes or in your EMR. The best part is it also ignores any conversation which the doctor may have to another person as he is examining. That is completely removed. The AI is able to understand that it doesn't belong to this, and it is capturing only the data. And patient can speak in Tamil, can speak in Telugu, Hindi, and it is able to capture that in English. So it can also go ahead and give us the diagnosis. It also tells us what investigation, but we don't want to use that at this point of time, as that would, it'll again need validation, which we have to go through. So right now we're looking at seeing how this is possible. I think Ronnie George and team also at Shankar Nethrali are exploring a similar application for capture, because this will save a lot of frustration and burnout for the doctors and the optometrists who are entering data for a long time in the EMR. We're also seeing, we have what we call as primary eye care centers, where we have trained ophthalmic technicians in the rural areas to screen patients and then through teleconsultation consult with a doctor in the base hospital. So they do a complete eye examination just like a eye doctor would do, enter all the data in an electronic medical record, and then consult with the doctor who's able to see who's sitting in the base hospital, is able to see the case sheet, and they look at the patient's images as required, and then talk to the patient or face to face, then tell them what they need. They need glasses, or they need a surgery, or they need, to apply medicine. So today we are seeing almost about 3,000 teleconsultations every single day through these primary care vision centers. But what is challenging is to have trained ophthalmic technicians in these rural areas. So what can we use AI-enabled systems to triage in the primary care centers, so that patients who have a problem is identified, and then they are the ones who consult with the doctors, and those who do not have need not consult or talk to the patients. Talk to the doctors. This way, you'll have more people coming into the system, and that's what is happening with our vision centers. So this is something we are exploring as an Indo-Australian project, because if it works here, they want to scale it up in the Aborigines in Australia. So we have really witnessed some great AI innovations in ophthalmology in the last 10 years with multiple image-based activities, like be it OCT, OCTA, and things like that. So I'm not going into the details of it at this point of time, just to say that there are a lot of work that's happening with fundus images, with OCT images, and many other, as I said, even in the cornea lesions, to identify, like you just think about it, your OCT machine will come with the report generated as you take the OCT or a OCTA. It will be able to identify each lesion and label it and show it to you, so that you don't have to spend time looking at that data, and then you can start planning for what you need to do next. So technology is very fastly evolving, like over a period of time, from machine-centric manual records. Today we have electronic medical records. Real-time data is being generated, and with the use of machine learning, we're finding multiple use cases. With this, we don't know. There could be a lot of potential for improving our clinical outcomes as we see patients. So the biggest shift we see is our insights were on what happened backward looking. Till 2020, we were looking at the data, but the current digital power combined with the information opens up new possibilities for improving caregiving processes, predictions, which will go a long way in improving or preventing unwanted outcomes, improving operations. And we need help in real time to do things right the first time and every time. But the danger isn't the technology itself, it is how we choose to deploy it. So the question isn't whether AI will cause layoffs, which is what everybody asks after I give a talk about using AI. It's whether we have the vision and leadership to use AI responsibly to amplify the healthcare workforce and not to shrink it. So at the end of the day, AI is not here to replace the healthcare workforce, it's here to reshape it. As I said, AI in ophthalmology is already a clinical reality. AI as a co-pilot, and it is not a replacement for any of the health workers. And it is possible to create access to care in rural areas. Shift towards predictive and preventive care will become a norm. Moving from diagnosis, prediction, prevention will enhance access, accuracy, and affordability. On the lighter note,
this is what I've been working on. Ow! Ow! Dude! Ow!
Playing for whatever reason. So in conclusion, the healthcare delivery landscape is evolving rapidly. Hospitals in India have to embrace IT responsibly to improve efficiency, accessibility, and quality of care. With innovative solutions, we can ensure equitable and effective care for all. So with this, I just wanted to share that AI is a way forward. They say it's not people are going to lose jobs, but they say that people who learn to use AI will be better off than people who do not learn to use AI. It's like they say that's the new electricity. Today, do we live without electricity? I don't think so. So thank you. And that brings to the end of my talk.
Thank you so much, Sir Dr. Kim. It was a wonderful talk, very illuminating, very informative, and I think much needed to inform us all and keep the younger generation updated. And like you said in your concluding line, AI is not here to replace us. We have to understand that it is here to empower us, to increase our efficiency, to save time, to increase our accuracy, and also to increase the accessibility. So I think that's something that we all should keep in mind. One question to you, sir, is that what are the challenges you think that people are going to be facing in integrating AI into their clinical practice? Is it the cost, or is it that we don't know the algorithms, we don't have the technical know-how? Is that needed? So something on that.
So one, you have to understand that AI is here to stay. So what are the technical challenges? It is going to take some time for people to understand which one to use, what to use, what is the right tool that I should use for my practice. So just like you buy an equipment or anything, today we are going to have, it's not like you're going to develop an AI algorithm. You're going to have off-the-shelf algorithms, so you need to know which ones to buy. But I suspect that most of our tools will come embedded with these AI tools in the future, which is how I see. But in practice, of course, like these electronic medical records and all that will change the way you see patients. It brings in a lot of norms. The AI will drive you to do the right thing the first time in case you're making a mistake. Those kind of things are possible, but it's still some time away. I wouldn't say it's here, but it's something that we are all experimenting on, but I'm sure it will come in time. You have to understand it is here to help you, not to remove you or not. AI is not going to do everything for you. You still will be the master. You will still be the controller of the entire tools, whichever you're going to use. But definitely, as I said, the outcomes, whatever you're looking at, we are looking at seeing, can we predict visual outcomes, after a cataract surgery, just by using AI? This is something we are experimenting on. Like I know if this patient is not likely to have an improved outcome, then I may have to be careful calling in those patients early on and things like that. So, I mean, these are some of the use cases that we think as we go on, I think we will find a lot of use cases. Each one of us will start learning with time.
True. Thank you, sir. So with that, let's move on to the panelists. Dr. George, you've also been working with artificial intelligence in your specialty. So give us an overview of that. How is AI being used in glaucoma diagnosis and follow-up, and any other perspectives that you may have?
Yeah, so I mean, glaucoma has been one of the areas where AI has been looked at. It has not been as successful as diabetic retinopathy because one of the challenges that you have in glaucoma is defining the disease is difficult. So if you're going to define a disease as being everybody who's got a visual field defect, then you're going to miss people with very early disease. If you're going to define disease based on everybody who has a suspicious disc, then you're going to overdiagnosed disease. So the gold standard is difficult to define in glaucoma, and that's one of the reasons why, while you have a lot of optic disc based algorithms which will predict disease, they've all used different gold standards to define it, and therefore they're not uniformly applicable. On the other hand, if you define an algorithm which can detect moderate to severe disease, then you can take the screening question out of the picture, because those are the eyes you don't want to miss. And those are the type of things that you would like to use in a community-based screening or in a vision care type of model. So those are the eyes that you don't need to miss. The other thing that AI has been used to do is to classify visual fields as being normal or abnormal, and to look at whether visual fields are progressing or not. The problem when you look at visual field progression is that the process is very slow. So unless you have large longitudinal data sets, which are at least of patients followed up for 5 to 6 years with a good number of fields, it's difficult to run those algorithms. So there are a few groups which are working on these conditions. So in glaucoma, because of these reasons, except for the optic disc, the adoption has been a little slow. And I'd just like to add to what Dr. Kim said, and in fact just reiterate what he said, is that we will probably first start using it as an assistant in our clinics to help us to take dictation, to help us to summarize notes, to help us to do case summaries. And that's, I think, the low-hanging fruit. It'll help with our efficiencies. When it helps us in triaging our patients, we'll be able to work faster and possibly spend more time with the patients who actually need it, your difficult cases, the ones who are progressing, the ones whom you need to talk to. And that's how it's going to impact us. But this is still a little way away for two reasons. One is not all our hospitals have the infrastructure to onboard AI at this time, in the sense all your data is not connected, all your imaging is not connected. We haven't, let's say, we haven't planned for the huge amounts of storage that we might need if we are going to use a large data-based or image-based network. And there are very few universal mature models available that all of us can use. And there is some data out there which suggests that we may require any model that is maybe tested in the West to be rechecked on our data, because especially black box AIs, you don't know how they make diagnosis. So yeah, we are probably at an inflection point. In the next 3 to 5 years, you're going to see it coming more and more into our clinics. And there will be few surviving models at the end of it that all of us will be using. And I think we will need to adopt it. We will need to adapt to it. And as Dr. Kim says, I think we should not fear it, but we should welcome it with an open mind and with caution, both together.
So, Dr. Arora, you're a retina specialist, and in your field of retina, what do you think is going to be the impact of AI in the next 5 years? Where do you see it, its place in the field of retina?
The first thing first, Dr. Kim has nicely summarized, and Dr. Ronnie has, added a lot of, info as to how AI can be adopted. It's a new tool and we have to learn it. As I see it, that, if I was, and see, I'm working as a private practitioner, and I would like, so we have a team, but of course, there's a crunch of human support system available. So if I have a screening tool which can tell me, supposing in my workflow, an undilated pupil, which patient needs dilatation immediately from a non-mediatic camera, these patients can be dilated, and then we can proceed further. Then, we have now tools which look at only, say, diabetic retinopathy. But as an ophthalmologist, if I want to look at the fundus, the same patient may be having diabetic retinopathy as well as maybe having glaucoma, maybe having anemia, maybe having age-related macular degeneration, or maybe having something else. So we have to have models which look at all these diseases at one go and give us some sort of an interpretation. I think Singapore have been doing with the Selena Plus, which has been now they have worked in Singapore as well as in Europe, and that has been adopted, which is looking at all these factors at one point, and I think Dr. Kim can elaborate it further on. And the other thing which is important with any AI tool is what is coming up now is what is called as an explainable AI. You remember the talk which was given by Sundar Pichai a few years back, that by looking at the fundus image, Google was able to predict the sex of a person, whether this is a male or a female. And actually, we never understood how did AI, what was the factors AI considered as to what is there in the fundus which makes a fundus male or makes a fundus female. And we don't know. So those are the factors which are eventually going to come up, where they call it as an explainable AI, that whatever the AI tool is doing from the large data, it will be able to tell us why that interpretation was born. As Dr. Kim rightly said, what would I like to do, or what are the things which we don't know and the AI may want to do? And then maybe as an expert, we will become wiser. We will start looking at those factors. So that is where I feel that AI is not something to be afraid of, but it may be a tool to improve our working, and also probably to give us a little more free time to develop our own self as a human being. That's what I feel.
True. Very well pointed out, Dr. Arora. So, Dr. Anil Gangve, what would be your perspectives on this topic?
So I think I have been working on ROP and how we can explore the AI in ROP. So I would actually just brief you about what are the difficulties of integrating AI in ROP as compared to diabetic retinopathy. So the first challenge that we face is, as Dr. Ronnie George was also saying, any clinical field or image where there is great amount of subjectivity or inter-individual variation, like cup disc ratio. Similarly, in case of ROP, now there has been initially it was a problem that whether to call it as a plus disease, pre-plus or no plus. So based on these plus disease, people used to either label it as a treatable or severe ROP or a disease which requires follow. So this type of subjectivity in case of ROP always do exist. And again, if you look at those model, so they need the training in terms of measuring those detailed vascular caliber. These are the certain arteries, these type of blood vessels, they are called as vein, and this is the actual caliber of a normal preterm infant, and if this is dilated beyond this point, it will be called plus disease. So this type of image database is much required. And plus ROP, as opposed, of course, diabetic retinopathy also has so many systemic factors which are playing in to have some effect in the fundus. But in ROP, many factors like the weight gain, the amount of anemia or hemoglobin that the child has, it also influence the kind of clinical picture that we tend to see. And as sir was saying, AI is principally based on how good images are being captured and how good has been the processing of those images. Then only AI will be accurately able to identify the type of disease that we need. So right now in ROP, people are primarily concerned or they are focused about distinguishing between a treatable ROP opposed to a disease which can be followed up. That has been the type of development that has been there in ROP. And a full-fledged ROP being managed by or diagnosed by artificial intelligence, it would do require some time, at least at least 1 decade. That's my thought on that.
Thank you, sir. Dr. Kim, what are some of the ethical aspects of using AI in clinical practice? So, if you've made a diagnosis and you go wrong, so who would be the one to be blamed? The clinician, the AI, or both? What do you think is going to be the way forward?
So
Because
as I
that's one the ethical concern is something that is going to come up in the future.
Yeah, that's right. Like in telemedicine, this has been talked about a lot as to who's responsible for the diagnosis. In this point of time, as of now, today, I wouldn't say AI diagnosis will be a standalone diagnosis. It has to be, like screening for diabetic retinopathy is set aside. I'm talking about in a clinical setup when you're seeing and then you're relying on AI diagnosis. I think it's still some time before we are convinced that AI is not making any mistake or making wrong diagnosis. It can make errors. So still that is being validated in certain areas, but it cannot be a standalone developing diagnosis or coming up with diagnosis and then you work based on those diagnoses.
Okay,
So the ethical part will come then when it becomes an independent decision maker. Yeah.
True. I think in the future then that's.
But I don't think we'll go there. It's my feeling on
Never
this.
say never.
Yeah, I am saying this is always an assisted tool, not
Okay.
not to replace your thought process.
Can I just say
Yes,
something?
please.
Ethical part also, when we are capturing data from patients, the images, and we are taking a consent from them, and these images may eventually be utilized for lot more purposes than what they have been taken at that point of time. Will that also come under part of ethics?
It depends on what kind of a consent you are taking to the patient. So, whenever you do a blood test or whenever you're doing a fundus image, even otherwise, you're taking a fundus image, you're making decisions on that, you're using it for publications, you're using it for research. So these are included in your consent, and patient understands that. So, and then unethical uses, like when your patients, if you're using unidentified or data that is not de-identified. If you have the name or patient identifiers in those images, then it becomes unethical. So that's data privacy and stuff like that. Yeah.
So we have a question in the chat box. How should postgraduate students and young ophthalmologists prepare themselves for an AI-driven future? Should they acquire technical skills beyond medicine? So, Dr. Kim?
I don't think technical skills is not required. Today, even the technical people are going away from that because those even the coding and all that is being done by AI. It's not the AI, the developers who are doing it. So really, technical knowledge, what is very important is how do we use AI? What are the opportunities, like Dr. Ajay Arora beautifully described about understanding a patient who has to be dilated versus not dilated. In the busy clinical practice, it makes a big difference. Trying to understand those use cases are very important as a clinician, but there are AI tools that can help you. So it's not understanding technically, I don't think is a requirement for a postgraduate. Of course, you should know what are the basics, what is available and stuff like that.
So, sir, do you think that AI is going to be also integrated? I read somewhere it's going to be integrated into microscopes, operating microscopes, and could actually tell the surgeon, which steps to do when, or if he's, making a mistake, the AI could prompt the surgeon. Do you see that happening in the future?
It is possible. Like one of the things that I was mentioning is about evaluating the surgical skills of the surgeon. Of course, that is running through the video and trying to understand where they are making mistakes and stuff like that. But I guess in future it is possible that, as you operate, like my nurse who's assisting me will tell me, sir, your incision is going deeper, or so because that's what they keep seeing repeatedly and they've learned from that. So I think it's a very much a possibility that it can happen, but I'm not sure if it exists at this point of time.
So the other panelists, anything that you would like to add?
I think Dr. Kim pointed out very beautifully, which I think is a little perplexing at times, is how by looking at the external photographs, you are able to, look at a lot of systemic diseases. And when you look at people's faces, we were taught, that a person has puffy eyes, what to look for, how do you look for, a person walks into the clinic with a pedal edema or has a sacral edema. So a lot of things we learned during a clinical practice. Now, probably AI is looking at a lot of these factors and giving us data which we never imagined. For example, by looking at pupils' reaction, the speed of reaction, the speed of constriction, we can predict about diabetic retinopathy. So, which is, I think, very amazing as to where AI is leading us to.
I'm not sure if you heard about this. I think I mentioned this in the past about an app called Anura. This is made by a Canadian company where you just with your smartphone, you just take a photo of your face. And within a few seconds, it processes it and gives you 23 different parameters, systemic parameters, like what are your chances of getting a cardiac thing? What are the chances you become a diabetic? I don't know how this is happening. And they've given it for FDA. They've applied for FDA at this point of time. So this is just by taking the whole face. They say it reads the blood vessels in the eye and something on the face. I really don't know how it works. So those are things that are happening.
I'm not sure. I think maybe Dr. Ronnie and Dr. Kim can tell me that I believe that now FDA is insisting that whatever is being approved by FDA should have a rationale behind, which is called as an explainable AI. For whatever models come in the market, they have to have an explainable AI. Is that true?
I'm not sure. I'm not aware of that. But of late, they are actually making it easier to get, I believe, AI-based algorithms, not for just healthcare. Of course, healthcare goes through a lot of this, but explainable AI, is it mandatory? I'm not sure. I don't know. Dr. Ronnie can.
I'm also not sure whether it's mandatory, but I think it's much easier to get an approval if you have an explainable AI, because there have been challenges with the sort of black box AIs in the past, where in certain situations they have miscalled or misled a treatment path. So I think it's much easier if you're explainable, but I'm not sure whether it's mandatory yet.
So I think we've had a very good discussion. Dr. George, any parting comments before we end this discussion?
Just that one about the residents asking whether they need to have technical skills other than ophthalmology. I think you don't need to. I think you still should try to become a good ophthalmologist and just be AI literate. You should understand the terms so nobody takes you for a ride. I mean, that's about the only advice I have for them.
Dr. Gangve, any parting perspectives before we end?
Again, I think I would just add on to Dr. George's message that as a resident or people who are young, they should have very good clinical skill, because AI might help you to diagnose certain things, but to treat, at least in right now, AI is not in the treatment part in medicine in most of the it. So you need good clinical skill. AI may help you for decision making, but ultimately you will be the person who would be operating or who would be treating that patient.
Very well said. Dr. Arora, anything you'd like to add?
So I would again say, as you know, Dr. Kim and Dr. Ronnie are working in institutes where they have second, third, and fourth opinion available. People who are working in remote areas who may not have the options of a second or third opinion, I think the AI, a good AI tool might help them in feeding the data, coming out with a second opinion whenever it really matters, so that you feel that there is a support available. So you should always take AI as a supportive measure, maybe as a second opinion at times, to make your skills better, to become a better ophthalmologist. And Dr. Ronnie said, learn your ophthalmology well, and maybe with AI, you could become a still better ophthalmologist. And then you can, of course, call up your friends and become a better expert. That's what I feel should be done. Not be afraid of AI, but to take it as a support.
Thank you
What
so
is
much.
important is that they should not use the AI to learn ophthalmology.
Oh, that's true.
That's where you lose this thing, because today everybody is bringing it, and then all your answers are driven by AI. That's where you lose your skills. It is important that they learn, as Dr. Rani mentioned, the basics of ophthalmology really well.
Thank you, sir. Very well said. And thank you so much for walking us through the changing landscape of AI today. It's been a very, very informative and illuminating talk. Thank you so much. Thanks also to all the panelists, Dr. Ronnie George, Dr. Ajay Arora, and Dr. Anil Gangve, for all your valuable perspectives. And with that, we come to the end of this webinar. Wish you all a very good night. I think wonderful knowledge was shared here this evening, and the postgraduates must have benefited. And again, for the knowledge of the postgraduate, this is an ongoing PG teaching program. Every Thursday, we are there at 8 p.m. with something new. There's a journal club or an investigative modality or a didactic lecture. So I request the PGs to log in every Thursday at 8 p.m. With that, thank you once again, Dr. Kim. Thank you so much for taking out time. And thank you, panelists. Thank you, audience. Wish you all a very good night.
Thank you, Dr. Tinku. Thanks a lot
Thank
for
you, Tinku and Prashant. You guys are doing a great job. Thank you very much.
Thank you.
Thank
Thank you so much.